Welcome, everybody, to today's podcast. I'm Dr. Alexandra Papaioannou, and I'm delighted to have two distinguished guests with us, Dr. Christopher Patterson and Dr. Irene Turpie. Both are leading experts in geriatric medicine with decades of experience in the field. Today, we'll be discussing the evolution of geriatric medicine, both in Canada and internationally, the inspiration behind their careers, the power of collaboration, and the biggest challenges and achievements in geriatric care. Thank you both for joining us today.
Thanks for having us.
Thank you for having us.
Let's dive right in. Dr. Patterson, Dr. Turpie, how has geriatric medicine changed since it first began? What were some key factors that helped it grow over the years?
Well, in some ways, it hasn't changed at all. We're still facing the same challenges that we did when we started in 1981. And those changes were obviously present for years beforehand. And I was looking through some of the writings of Dr. Marjorie Warren, who was regarded as the mother of geriatric medicine starting in the UK. Where she took on the responsibility for over 800 so-called chronic patients in a workhouse and began to systematically examine these people and introduced a multidisciplinary team for rehabilitating those that were able to be helped and actually discharged about 1/3 of them back to the community. And some of the things that she said at the time were that bed rest was extremely bad for you and that deconditioning was a major problem. She introduced a number of rehabilitation techniques, including actually joining in the rehabilitation exercises when she felt that the patients weren't being enthusiastic enough. And she referred to this as, I thought this was kind of neat, she referred to it as therapeutic rage as a stimulant. And although I don't think we've adopted quite the same techniques, we certainly encourage the ambitions and the aspirations of individuals in promoting their own rehabilitation. I think one of the other challenges which still remains is that identifying what we do remains a problem. So that's enough from me, I think.
Okay, well, I came at it from a slightly different and less academic angle, perhaps, in that I was fortunate. I didn't know Marjorie Warren, but I was fortunate that in my medical school, even as a medical student, there was some interest in geriatric medicine, and Ferguson Anderson was the first professor of geriatric medicine anywhere, and he was, of course, from Glasgow. But he once took me to a hospital. I think I must have been a final year student or a resident or something very early in my career. A dark, dingy, damp, miserable hospital where there were old people sitting in beds and you could smell the urine, and it was really very distressing. And I can remember thinking, oh, wait a minute. And lost all my ambition at this point. I think I've told you this. I lost all of going to far countries and improving medical care there. And that's when I began to get interested in it. And when we came to Canada, there was no geriatric medicine in Canada. There was no official geriatric. People thought we were nuts. I went up to work in a local care home for the aged. That was the first thing I did when I worked in Canada. And again, you saw people just basically lying in beds. they took me into the residency program here at McMaster. They didn't have a geriatric program, but they let me do all the things that they thought were appropriate for geriatrics, rehab with Alan Bass, who was a great guy, neurology. There was some great neurologists here who taught me lots of good things. Anyway, and then I was fortunate enough to go back to Glasgow to do another 6 months of geriatrics. And then when we came back, Christopher was here when we came back, and they'd started the Shadok Geriatric Assessment Unit, and that was where we worked for several years. But let me tell you, it was a different. He thinks that nothing has changed. Let me tell you, things have surely changed since then. We could admit patients from home to the geriatric assessment, which we can't do now. The patients, I was just saying before we started, the patients were gotten up out of bed and taken to the dining room, walked themselves to the dining room to have their meals, and lots of things that are no longer are the staffing or the availability to do now. So things have changed. And the other thing that has changed, and I think we geriatricians get a lot of credit for it, Christopher. And I'm going to ask you this question again. When you were up in the GAU, how often did you do an MMSE? How often did you do a formal mental status test?
Not very often. In fact, when we started, I'm not sure we had heard of the MMSE,
Correct.
And we certainly hadn't heard of any frailty scales. And no, you're absolutely right. We have changed a lot over the years.
And that change we have taken into general internal medicine, into surgery, and into family medicine. And I think we deserve the credit for that. We deserve the credit for making people, because when I was in the geriatric assessment wards in Glasgow, that was supposed to be top of, but nobody looked at mental status. And I think we geriatricians have taken that into mainstream medicine, and I think we need to congratulate ourselves for it. And ditto for frailty and Ken Rockwood's work here. And we've even got the Montreal assessment scale from Canada. 2 enormously important instruments developed here in Canada, which I think we should be very proud of internationally. And then, so that's 2 huge things that geriatricians have put into the mainstream medicine, don't you think?
Yeah, no, I think you're absolutely right. I think when we look back at the beginnings of geriatric medicine in Canada, the path was not smooth. Even though the Royal College of Physicians and Surgeons of Canada declared in 1977 that the specialty of geriatric medicine should be recognized, there was tremendous opposition from the internal medicine in the Royal College and
all the men
and and from family practice too, and it was an uphill battle. Yep. Finally, it was.
What do you mean? We look after old people. We know how to look after old people.
That's right. Yes, that's right. Yeah, the cardiologist said, well, every old patient's got a heart, therefore we understand old people. It was really quite bizarre, the arguments that they had. The same with family medicine. They say, we've looked after people for years and years and years, so therefore we know all about it. So I think trying to define our specialty was always difficult, because the argument was there's no special body of knowledge that you need to treat older people, and you have no special techniques. And those were the 2 things that our colleagues, I think,
but we soon showed them wrong.
We did. We proved that. We proved that there is a knowledge base that is unique to old people, and I think it's even more obvious now in the intervening 40 years that people do recognize that older people are actually rather different, and not only rather different from younger people, they're rather different from each other as well. The heterogeneity of older age, I think, is something that many people even now don't quite grasp.
I really want to ask you, both of you have had remarkable careers in geriatric medicine. What inspired you to pursue a career in this field, and what keeps you passionate about it? Because you can hear the passion in both your voices.
Well, I think what inspired me, and I think it's inspired many geriatricians, and I used to ask the younger ones, and they always had enough. What inspired me was I think my grandparents. Most geriatricians have amazing grandparents, and that are people that they could talk to. One of my grandparents once, I think I've done this to you, Christopher. I'm not going to do it because it's not on the thing, but shake my hand. And my grandpa said to me, and I shook his hand, and he said, Irene, always remember that you're one handshake away from the Battle of Waterloo. That was in 1815. And so I've been shaking all my grandchildren's hands and saying, remember, you're only two handshakes. And that sort of gives you a sense of history. And so does talking to our patients give you a sense. I mean, I was thinking this week about your patient whose husband was the hero of Chariots of Fire.
Indeed, yes.
And telling this story, during the Olympics to my grandchildren. Well, I once met someone
yeah.
And that's so really the patients that we meet and look after are the inspiration for geriatric medicine, for sure, and doing things better for them.
In my case, when I first came to Canada, I worked as a general practitioner in Northern Ontario, and I found that the older folks were so much more interesting than the young people, mostly because of the stories they told. So that was one of the things that made me interested in older folks. And then when I started my internal medicine residency at Queen's University, the very first rotation I had was in geriatrics. Everybody else, all the other residents said, "Oh, that's bloody awful," and they had a miserable time on it, and I absolutely loved it. I found my niche there. It was exactly what I wanted to do, and I never looked back after that. So that's what turned me on. Certainly, my grandparents. I didn't know my mother's parents, but my father's parents were very interesting people. My grandfather was an electrical engineer and was actually in charge of the largest power station in Rangoon. So very, very diverse on my father's side.
That's fascinating. So collaboration is crucial in healthcare. Can you each share an example of a successful collaboration in your career? Who was involved, and what did you learn from the experience?
If I may mention this one, Irene, because this is the one which I think we both found extremely helpful. Day hospitals were quite popular in the early days of geriatric medicine. And Irene had the idea that we should do a randomized controlled trial. So we set about doing a randomized controlled trial. And we had as a mentor, Gordon Guyatt, who, of course, everyone knows as being one of the founders of evidence-based medicine. He was extremely helpful. And our research associate was the wife of Dr. David Sackett. So we had...
Her name was Barbara.
Her name was Barbara, yes. Anyway, Barbara Sackett was absolutely wonderful. She was very good for us. And Gordon Guyatt, of course, was the methodologist involved. And that was a wonderful collaboration. We learned so much about research. And I think we were both doing master's courses in research methodology at the time. So it all fitted together very well. So that was one outstanding collaboration.
Well, I mean, these are excellent collaborations, but the other collaborations that mean such a lot in geriatrics are interdisciplinary collaborations. I mean, when I think of some of the wonderful nurses and occupational therapists and physiotherapists that I worked with up at Shadoke, that I worked with at St. Joe's, and that I worked with when I was down at the community health center. I learned a lot from them. They learned a lot from me, and we sort of the whole concept of teamwork was just growing into medicine as we did, as geriatric medicine developed, and I think that was a really important another important thing that the geriatricians did. They really appreciated teamwork, and that's a collaboration that I would say I cherish too.
There's a quotation from Sir Ferguson Anderson, who Irene mentioned as the first professor of geriatric medicine in Scotland. He was quoting Marjorie Warren, who said that rehabilitation would fail unless all on the unit were, quotes, from the matron to the ward maid.
That's right. That's right.
And when the whole team works together, you can achieve outstanding things. And we've been very fortunate over the years to have wonderful collaboration from our interdisciplinary folks.
I can remember Tom Airy or Ferguson Anderson or one of these people that I worked with when I was training saying exactly that to me. If you really want to know what the patient's thinking, Irene, go and ask the ward maid. Go and ask the person that tidies up their bed and sweeps the floor, because these are the person often that the patients feel most comfortable talking to. And I used to do that. I used to get all kinds of information.
And have very valuable roles in things like keeping people hydrated. I mean, how often have you walked onto a ward and there would be a big jug of water and a glass that is out of reach of the person in the bed? And that simply, moving the water closer to the person and making sure that the top is off those awful plastic containers that the patients have to dismantle before consuming their juice for breakfast.
Anything else, Dr. Patterson and Dr. Turpie, you'd like to share?
The original concept, I think, of geriatric medicine included things like fall, cognitive impairment, and incontinence. I think that was 3 sort of pillars originally, and then the number of pillars increased. And in Ronald Cape, that I worked with, had this concept, the O concept, the Olympic O's. And his O's include cognitive impairment, incontinence, falls, but added medications and their adverse events, and failing homeostasis. So that was his 5 things.
That's right.
And then I think the introduction of the 5 M's of geriatric medicine has been very helpful, because it does help other folks to relate to the things that we do all the time. The 5 M's being mind, obviously including cognitive issues and affective issues and so on. Multimorbidity, because we're always dealing with multiple pathology. Medications, and mobility. Did I say that one? And the final thing is M, what matters. And I think those 5 M's really encapsulate what we do. And I think it's easy for other people to recognize. So I think that's been a huge advantage in being able to define our areas of expertise.
And I would agree with that. I think that these M's are an excellent way of putting it. And what has happened through the years is that people have realized, and I can remember it took all of us. It used to be that we have all these multiple specialties. But what the geriatrician does is pull the knowledge, pull the different diseases into one clinical scenario or one clinical picture. And I think doing that, and our doing of that, has made an enormous difference, both in research and, more importantly, perhaps, or just as importantly, in patient care. And because of our understanding, and I give the geriatric programs the credit for this, there have been all of these wonderful programs developed exercise, for nutrition, for dealing with medications and all of these things. And I just wanted to tell you as an example of what I can recall from my own experience. I can remember once sitting down with a surgeon in the ER and saying, you know, you guys need to start looking at why somebody had a broken bone. You guys need to start looking at why patients fall. Remember, we used to say falls are boring, and that's what everybody would say, boring. But we would say, look at the cause of the fall. Not one of them are boring. And this guy was actually quite turned on by this lecture I was giving him in the emergency room. And he was arranging for the emergency physicians of Ontario for their annual meeting up in Toronto. So he said, talk to us about falls, Irene. I said, sure, I'll do that. Happy to do that. Went up to Toronto, and here was this talk on falls. Do you know how many people came to it? Have a guess. Alex, I think I've told you this before. Yeah, there was 2 people came. One was the person that I'd suggest. Now, if you were to go to a talk anywhere in Canada, anywhere in the world now, and have falls causes and how to go about them, you had it as a highlight for the geriatric day last year. I think falls, or look at the difference it's made, and what has made that difference is geriatric medicine.
In the early days at McMaster, Irene gave a medical grand round, which was entitled Falls, Boring, Syncope, Exciting. And I think one of the things that I would say about my colleague is that her educational abilities are quite outstanding. She's had tremendous influence in education through the Educational Centre for Aging and Health, for example, through her outreach in far worlds, such as through the MSF in Africa. And I think her biggest accomplishment is being able to stimulate the interest in students and literally light the fire in their belly.
Oh, well, on the other hand, Christopher, your knowledge of medicine has always impressed everybody.
So thank you both for your insights, for your humor, and for the incredible work you do in advancing the field of geriatric medicine. It's been an enlightening conversation, and I'm glad you inspired a number of generations of learners to choose geriatric medicine in Canada. Thank you to our listeners for tuning in. Be sure to join us next time for more discussions on the latest in healthcare and medicine.